there's two things. One is I always had a very athletic-minded drive in me to try to pursue athletics when I was young, and the idea that my abilities in athletics were less than stellar, so I still wanted to be associated with them, and to then coach was a dream of mine when I was in high school. However, in the sciences, like physical therapy would demand, I did not ever feel I had the confidence to be good enough at sciences to get into it, like a science-related field. So I went into history and a minor in PE. And as I finished those degrees and started teaching, I had a cousin and also a very good friend that were in PT school at the same time at both UCSF, University of California at San Francisco, and at Stanford. And I visited those two people, and I was very encouraged by the faculty from both that, you know, I should apply if I'm interested and I'm this driven. So I went back and established the prerequisites and found out that I had the ability to handle the sciences, and so therefore I said, this is what I want to do, because it employed a very strong background in wanting to work with people and coach people through their dysfunctions, and the motivation part, but also the fascinating aspect of the science of it, of learning muscle physiology and the nervous system that produced that. Muscle contraction, for example, that all was just very, very fascinating. So that was kind of like the foundation that brought it on.
Throughout your education, what guided you towards orthopedic manual therapy?
Well, I was very blessed at the conclusion of my program at UCSF to have a family friend who was a physician at Kaiser Health Maintenance Organization that was in California, and he was in that position when Kaiser was originally forming in the early 50s. And so he was affiliated with Kaiser Vallejo, in that he was a Napa, California physician, but the main hospital that Napa Kaiser members would have used would have been Kaiser Vallejo. And of course, Kaiser Vallejo is famous for the proprioceptive neuromuscular facilitation program. So he encouraged me, this physician, that if I ever had the opportunity, that this program would be a wonderful thing to have as a physical therapist, and that physical therapists from around the world were on a waiting list to get into it. And so he told me about it, and so I was very interested in looking into that. And the cousin that I had that had been in the Stanford program, who had visited, was in that PNF program when I decided to go visit her and see what it was like. And I met Maggie Knott that day. And later, as I was in my internships for UCSF, I got a call saying that we have an opening for this next class because a German had canceled at the last minute, and realized at the time there's a 5-year waiting list. And I said, I'm ready and I'll come, you name the date. And it was October 1st, 1974, or 75 that I got into that program. So if you think about PNF and the facilitation, it's all manually driven. So with that experience, in 6 months, I realized that I knew very little of PNF as to the staff people that were there. And I asked Maggie if I could get hired. And she said, my budget doesn't allow it, but I could keep you on at your stipend and you could continue living in the dorm. So being a student, I didn't know any difference in lifestyle, so it sounded like a great deal to me. And so I just continued on there for 9 more months at that status. And I was learning, continually, and I had a great opportunity there because I was in acute care for 2 hours a day because they needed to staff the hospital. I was in outpatient therapy, realizing that was a whole different aspect of physical therapy I didn't know. And then I was in PNF and rehab, neuro rehab, 4 hours a day. So I had this tremendous learning environment of 3 different areas of PT to kind of grow me in this embryonic state of my career. And at the same time, this is the cool part, Maggie Knott had gone to a world conference in physical therapy in Heidelberg, Germany. And at that conference, she met Freddie Kaltenborn. And Freddie Kaltenborn and she had come to an agreement that he needed to know more about her system in exercising patients for his manual therapy background. So they arranged that his wife, Trouty Kaltenborn, would participate in the 3-month program, which was another program that Vallejo had. They had a 3-month program and a 6-month program. And that Trouty would take that program in exchange for Freddie Kaltenborn giving 2 lectures to the staff at Vallejo as an exchange. And then the person that was put in charge of bringing Trouty up to speed, because the 3-month course that she joined had already begun, was this guy that was single, didn't have a family, and had time on his hands after work to help her get up to speed for where the rest of her class participants were at that point. So I got to know Trouty, and that was a fantastic contact to make for the later development pursuit that I had for manual therapy. That then continued when I finished 2 years and eventually did get on staff at Vallejo, but then made this transition to leave Vallejo with my new wife, who was also a staff PT at Vallejo, and her name was Lynn Bollinger. I'm just going to slip that in. And we went to Norway, and we were there a year before my class ever started, not knowing if I would get in, and learning the language, and then got the opportunity to assist on a PNF class that was for all the people that were within the Kaltenborn avian system in Norway at that time. And then I was granted permission to take the course as a foreigner that started in 1979 for the 2-year residency program in manual therapy in Oslo, Norway.
How did you determine there was a need for an association for American manual physical therapists?
That's another extensive answer. Having been trained by Olaf Avianth, as was my principal instructor in Norway, and Kaltenborn was on the road much of the year, traveling throughout the world, teaching orthopedic manual therapy. And so the principal instructors I had in Oslo were Hans Gunnari and Olaf Avianth. And I had a very strong respect for them, and my program lasted 2 full years. And then I returned home to Folsom, California, and in coming home to Folsom, there was a great need in physical therapy to have something in education beyond weekend courses or week-long courses, and at that time Stanley Paris even had a 9-day course that physical therapists would go all day, and they were very technique-driven in the sense that you would learn a host of techniques, but when you learn so many new motor tasks all at once, you can imagine the retention on trying to be able to perform these techniques with patients and all the different patient presentations that there might be would leave one in need of having a more clinical background. And so perhaps to learn them in a concentrated amount of time wasn't the best way, in my way of thinking, the way I had been trained over the long program at Vallejo and over the long program in Norway. So I thought if I had a program that I could develop, it would be a little bit every week and we would go on for as long as the people were interested in continuing. So we started up with a 3-hour class on Wednesday night, and then we would run that class on a subject like thoracic spine till we felt like I had exhausted that area. And then we'd move on to another area. So as that program got off the ground and was had gone, in the first class was in December of 1981. By 1984, Freddie Kaltenborn had agreed to come to Folsom and be a guest lecturer, which I was just thrilled about, to have one of my mentors come to Folsom, and we attracted a pretty good group. And so he saw from the programs in the prior years that my effort had started, was getting off the ground, that this program was worth something, and that I was trying to have an ongoing education system that was done over time. And although we didn't have residency component yet, we were at least teaching people over time. And so when we continued that, he eventually convinced Olaf Avian to come. And Olaf Avian said, I won't come to any course unless they can have something of a decent table, because if you don't have a good table to work on, then how can the people ever hope to accomplish a task when that task may have the table go very low, especially for a short-statured therapist, or higher in order so the therapist doesn't get hurt. So he, unlike Freddie, who would be willing to do a conference almost anywhere on conference tables in a hotel, for example, with just a tablecloth on them, Olaf said I would never do them in hopes that the people could get something out of it unless it was high-low tables. So we were able to get Carden to loan tables to us, and we had a course in which Olaf came. And then Olaf continued to come for 26 more years consecutively, a week at a time. And as we began that effort, Freddie Kaltenborn was becoming very frustrated by the lack of the United States' involvement in IFOMPT as a full voting member country. And the implications of that is that IFOMPT was a system of the International Federation of Manipulative Therapists from around the world. But the US, although not a full voting member, had more members as far as PTs involved than any other country. And Freddie Kaltenborn really wanted to get the US to be a full member, but the US could not become a full member unless they were recognized by their national body, the APTA, and unless we had an organized educational system. And so he started asking me, what can we do to try to make this happen? What programs would need to come together in order that the APTA would eventually recognize us?
Did you have any idea that you're onto the trail of developing an American association?
Well, okay, I'm glad that you came in that direction. Because this is what happened with Kaltenborn. Kaltenborn was one of the founding members of IFOMPT, and I'm sure he was wanting IFOMPT to be even more firmly established, with the US membership being an important component to its ongoing development. So he asked me, who should we invite to try to get this going? And at that time, he had asked me to help him get a program off the ground at Oakland University in Michigan. And lo and behold, that was where Cornelia Kulig was interested in trying to get an orthopedic manual therapy program developing. Now, at that university, as I recall, the head of the Oakland University PT program on campus was a person by the name of Jane Walter, who coincidentally at that time, her interest was in peds, but coincidentally at that time, was the vice president of the APTA. And I think Freddie could see an inroad that this possibility of organizing a U.S. effort and coordinating it could take place with this inroad of his association with Oakland and meeting Jane Walter, who then would have a lead in to the APTA to help with some recognition. So he asked me, who should we invite to try to have as an organization that would represent the United States' many programs? So, of course, I thought of the Kaiser Hayward program, because they had a true residency like the Folsom program did, where you have people learning in your clinic that were under supervision of teachers with the patient treatments that they're doing. So it was a true residency following the medical model for that medical doctors go through. And of course, the huge players in the United States at that time were Stanley Paris and Ulla Grimsby, and I thought they had to be a part of it. And then Mike Rogers, who was trained by Ulla Grimsby, also in Norway, where it was a different part of Norway than Oslo, in a town called Kristiansand. Mike Rogers also had a residency program going in the United States, so he should be invited. And then Bjorn Svensson was another Norwegian trained physical therapist, and he had a program going in Michigan. So we had the program that Cordelia was hoping to grow and develop at Oakland. Then we had Bjorn Svensson, and then Mike Rogers, and then Hayward, and then Stanley Grimsby, and the Folsom program, and who have I left out? Richard Earhart in Pittsburgh had a program, and Richard Earhart was one of the first officers in IFOMT earlier. So of course that would be a great addition if we had all of those 8 programs involved. So we agreed to meet at that time at Oakland, where Freddie invited. Now, and Freddie had the international status that if he invited them, they might come. If Michael Moore invited them, or if Joe Farrell invited him, or Freddie, even Stanley might have invited all of us, we may not come. But Freddie had a connection with all those different players that they would respect him and his status in the world as a manual therapy leader, that they would want to come and listen to what he was proposing. So he, as I've always said, was the catalyst of the American Academy for me. He was the one that brought these 8 programs together that we would all agree to, that we need to come up with something, an organization that would allow us to be recognized as a force, and that term was commonly used in the early days, as a force that the APTA would have to recognize as being a body that would represent manual therapy, and with that official recognition could help us with our application to become full voting members to IFOMT.
What drove you to look past these differences in creating this organization?
There were differences. And the differences oftentimes were recognized from the get-go. Like both, I can remember Stanley and Ulla both at this, in the early days, saying, we don't have a formal residency like Mike Rogers had and Dick had, and we had at Folsom, and of course Kaiser Hayward had. But they could see that this would definitely be a component that they should have, and it would be a good idea that they would develop it, and then it would be a good thing for the education of the participant in it. And so for them to change their model that they had and to add this residency component, I think was a big gesture on their part to making this thing work. And then the areas where we really came to an agreement on was the fact that the safety of the patient should be first and foremost, and that there should be some agreement on standards of safety before different techniques might be utilized on the patient, so that there would be an agreement with that standard of safety among all 8 programs, that the recognition that patient safety should come first because of our differences on maybe how techniques would be applied or philosophies of treatment would be prioritized in the patient care, so that we would have our differences, but we recognize the importance of the evaluation systems that we all enjoyed as being something way beyond anything that was being produced in physical therapy schools, because of how much additional training you had to have for those evaluation skills, both the subjective part and the objective part of the testing that had to be done.
What do you think is your most significant contribution to the Academy?
The most significant, I think, might have been to try to deal with Freddie Kaltenborn in the early stages of this development and be a liaison, not between himself and the other programs, but to possibly give him the ideas of who should be included in this discussion if the United States were to try to take its most prominent programs that were programs in manual therapy that could be players in this proposed national body that would then have the possibility of being recognized by the APTA. So I think Freddie Kaltenborn seemed to trust me, and that meant that he would want to discuss different issues at any point in the day when he may feel like it on his 9-hour difference time zone, which meant I would get calls frequently at 5 o'clock in the morning when it was about afternoon wherever he was, in Germany or Gran Canaria or Norway, and then want to have these discussions on who we should invite and why. And so I would think it was kind of a background. We had a program at Folsom. It wasn't a program that was producing any big numbers, maybe 1 or 2 residents a year, nothing like Hayward, nothing that had the potential of a Grimsby, nothing that would have the potential of what Stanley Paris was already running. But it was a program that I think had good quality, and Freddie recognized that we were trying to put out a good resident, and so I think that would be something that may have had some value to the Academy as being a program and trying to keep Freddie grounded in the direction that we needed to move with these different programs and being inclusive with those programs so that we'd have a foundation to put forth to the APTA.
Briefly state 3 of your best accomplishments during your tenure at AAUNT.
I would say to list 3, I can't do that. But I can only go back to the first question, which what was the value of and what was my role, and I don't have much to add to that. I have saved several personal checks that I wrote that were airfares and hotel stays of when we gathered, and then upfront money that all of us would put up to get this program off the ground. Several checks that were written just because we needed startup money, and we all agreed to pitch in money for this startup. And I've saved them not to remind anybody, but just as a personal commitment of what we had in the hopes that this program would grow, and the time it was taking from the balance that we all try to have in our professional lives with our private lives. And I think that the time going to meetings demanded a lot of sacrifice for myself as a father of 4 children, and trying to have practice and have my own program growing, but still devote an even greater time to family and that balance that meant to me. And then I coincidentally mentioned that I had our program in my hometown where my parents were aging. And as they aged, I was the one who was one of the principal caregivers in their life. And that took a toll that I did not want to necessarily leave town as frequently as the different academy endeavors were pursuing with meetings. And so those kinds of things of attending meetings, I thought were, like we all 8 of us did, they were sacrifices, and there was economic sacrifices besides the time sacrifices. So I'm not trying to play a violin here, but those were all things that were necessary. Face-to-face meetings, not on Skype, but face-to-face meetings where you could read a person's emotions and oftentimes try to reach consensus that I don't think is that easy to do with emails and the electronic media that we have today.
What is your most proud moment? This doesn't have to be a professional accomplishment, but might be.
I was very honored to having received the Colton Boren Teach I Must Award, because I do feel connected to this profession in patient care, which I find still extremely rewarding. But also a second rewarding aspect of this profession for me has been to teach the patient treatment that I had learned from Maggie Knott in Vallejo with PNF, and as well the material that I've learned from Kaltenborn and Navian over the years to the different therapists that have come through our facility. And so it's been a quiet pursuit, but a very enjoyable one, and has helped me evolve as a person. And there are different evolutions to that where you could easily get used to being knowledgeable in the material you're presenting until maybe in another aspect of your life you're now having to learn some new task yourself. And for me, in 2004, I became very involved in ballroom dancing and had to learn with my wife new motor techniques, and had to feel music and emotion and get in touch with another aspect of my body that made me appreciate what the students that I was still teaching were undergoing. And so it got me out of that rut of just being the teacher that produced the knowledge that they had to share with the students, that I had to understand and have more compassion for the students and what they were going through as learning new motoric tasks for the evaluation skills or the treatment skills that we were asking them to do, and how so much repetition was needed, because you can ask my wife how much repetition I need on our new endeavor. But the fact that I was now at this point in my career in the 2000s appreciating what the students were going through at a new level, and trying to teach them the components of how we treat patients.
Tell me something about yourself that most members wouldn't know.
I feel I've been blessed with a gift of physical therapy, and it's evolved over the years in a way that I think it truly is a blessing, because there's too many incidences that have occurred that are beyond luck to have had the different mentors I've been blessed to have trained under, and then to have a partner who also continues to push me and push our program and have it evolve to a level beyond what I ever dreamed our program would be. My partner Tim McGonigal has taken it to a level that most people are totally unaware about the Folsom program. And I think I've been blessed with trying to balance these things in my private life with my family and my wife and my extended family with the practice. And so I account a lot of that to a faith in that I have, and I don't feel that probably that I've ever acknowledged that before.
Of the founders of Aon, choose two that you look up to and tell me why.
I think Dick Earhart would be one of the first people that come to mind for his willingness to take on a leadership role in IFOMT with the background that he had and his vision that the United States could someday be a part of IFOMT is a very wonderful thing that he was able to give to the Academy, and his experience with IFOMT and keeping the American Academy going in the direction that it eventually would be part of IFOMT. And I think that has been a wonderful thing that he gave us.
What are your thoughts on relationship between AOMT and IFOMT? What is the value?
I think to be recognizing that the world is becoming smaller, just like when we look at our journal JOSPT, and at first the advisors in that journal were all pretty much U.S., and now it's a very long list of international people that you see inside the front cover that are involved with being enrolled in our profession in orthopedics. And so I think the United States has definitely needs to recognize other countries and what other countries are doing in manual therapy or orthopedic physical therapy that can all help us help our patients. And some other countries may not have the restrictions that we do in the United States on just HIPAA compliance or economic ones with regard to insurance on how long or short we can treat the patients. And so these different factors may allow them to study and get some evidence that would serve our U.S. participants well, to know that another country has been able to find that they were able to accomplish this because they didn't have all the restrictions on them for research. Maybe they were able to do things more invasively with an EMG, or do things more invasively on seeing what people ate nutritionally with blood work that would help contribute to why their muscles heal or don't heal so quickly. So I think to stay connected with the international community is pretty darn important, and if we could have an organization that works with an international organization like IFOMT, then I think both are going to be served well.
How do you feel that AOMT has influenced and benefited the APTA?
As to my best recollection, the need for the academy programs to be accredited and recognized amongst one another as programs that would be recommended to physical therapists to apply to and participate in, needed to have some kind of accreditation amongst ourselves that we could tell the physical therapists in the U.S. that these programs would be recognized by the American Academy, and that we think that accreditation by the American Academy would have value, and that when the Academy started that, I'm not sure that the APTA had that kind of a process in place in which to accredit programs, but they certainly had the organization and the staff to help fund such a program that would accredit programs from a national body that a physical therapist could feel that the that program would be a program that had the national body recognizing it. So in light of that, I think, if my recollection serves me well, the attempt by the American Academy to accredit its own programs was a facilitator in having the APTA also accredit programs beyond physical therapy schools, but postgraduate endeavors like the American Academy programs we're trying to establish in their own right independently, that later then had the APTA start their own accreditation process, which the American Academy, as I understand it, turned that process over to.
So from your perspective, how has AOMT influenced our profession?
When I was in physical therapy school, we had 8 hours of manual therapy in the curriculum. And I think we have moved beyond 8 hours of physical therapy, orthopedic manual therapy in our profession. At most schools, having recognized that there's a definite high percentage of physical therapists that graduate from programs that enter outpatient orthopedic practice. And with that recognition, even though they have, the physical therapy schools have to prepare the candidates for taking their state boards across the level, so it's pediatric, and it's neurologic, and it's acute care, and then it's outpatient orthopedic, and then there's amputees, all these different areas for which they are responsible to prepare their candidates for licensure, that the orthopedic aspect of that curriculum represents a larger percentage of what is in the physical therapy curriculum as a whole than it did when I was first finishing. And I think that the American Academy, bringing forth programs that are postgraduate programs for therapists to enter, has had a big influence on the profession, as almost forcing physical therapy schools to get better at their presentation of outpatient orthopedic skills that includes the definite techniques that manual therapy employs.
What do you look forward to the most about the AM conference each year?
At this point in my life, I'd say it's a connection with people that I had early connections with, but I have to say that I'm also excited that I still enjoy learning. And when I see topics, for an example of people investigating concepts that I was presented with by Olaf Aviant, for example. I'll give you a good example that I gave to Shirley Sarman yesterday when I was here for her one-day course. And she was talking about the recognition that there's hypermobility that takes place in the spine that's caused by different impairments elsewhere, and those impairments then resulted in a diagnosis and pain that the patient was suffering due to that hypermobility. And there's evidence of the hypermobility now with the higher level of technology that can look at the amount of play that the vertebra has. For example, just this year in our JOSPT, they showed a new MRI that was able to take the subject and have them weight bear instead of supine, and saw the difference in translation of the segment that was suspect of producing the patient's symptoms that were pretty radical, but yet not radical unless they were weight bearing, and the amount of change that took place. So when you think back of our training with Olaf in Norway and trying to decide if the number of millimeters, the amount of play that was existing in translation at a particular segment was excessive and it produced the pain that he was labeling that hypermobile pathology. But yet there is an intertester reliability issue that it couldn't be taught and that people would all agree. And now there's sophisticated technology that is saying that yes, indeed, this problem that exists with too much play is the generator of the patient's pain, and that what needs to be recognized. Or the different influences that may be associated with that diagnosis, that's an impairment of muscles that he taught us to feel, like multifidus and rotatorius, that now there's evidence that people with long-term back pain have a fat infiltration to those muscles that isn't present with people that do not have a history of back pain. And he was teaching us to feel the difference between the muscle's response to our light manual therapy touch of the muscle and asking the muscle to resist our attempt to move it isometrically, and how there would be a difference between normal and abnormal at the involved segment. And so these things that were palpable, that the skilled clinician was teaching the unskilled like myself to try to be able to recognize on their patients, now has evidence behind it to show and verify what these people were feeling 30 years ago, like when Olaf Avianth presented this material on hypermobility, and that you can find in the 1977 proceedings of IFOMT, and that he wrote about. And so to come to a conference that has studies that now has technology that can verify that is a very fulfilling and rewarding thing to see. And then things that weren't even presented in our PT curriculum that would be involved, like the lymph system, and how that's going to play a huge influence on a person's ability to heal after they've had like a total knee, for example. And that recognition of that the lymph drainage needs to take place if the range of motion is going to be continued, and the right instructions need to occur from the therapist to give to the patient for that lymph drainage to occur. Even though you're not a lymph therapist, you as an orthopedic therapist need to be able to know something about that lymph system that was barely even acknowledged in PT school when I went through. So to hear these new places, new roles of different systems in the body, and the evidence that's coming about as to their role in the patient's healing, and the integration of the whole thing is pretty exciting. And even though I'm at the twilight of my career, at 68, it's still, for me, an exciting thing to see. And it's an excitement and rewarding thing to, when you get done with the conference, you say, yeah, I'm really glad I attended this thing.
For students and PTs who are not members of the Academy, what do you believe should be marketed in order to attract their membership?
The fact that they're gonna, with this organization and attending the conference, I think that they gonna have access to information that they should have, they need in their everyday practice. Whether it's a student who's entering into outpatient orthopedic, or the recent grad out there that's perceiving that they may have a handle on this because they've had it in school. I think that's a scary perception, that because one has had it in school that they're qualified. And they may have DPT after their name, but I don't care. I think that there's a very high need in our education that the students and the new PTs understand that a body like the American Academy can be a wheel that they use to take their level of practice to a level higher than what is present if they just go out of school and start practicing. And unlike the medical model, when you think about our doctors in medicine would go through a residency, and it's almost expected that you go through a residency, and that residency is going to be 3 to 5 years in which they're going to be supervised with patient care. We don't have anything mandatory like that, nor is there anything rewarding financially for the person to become board certified in a specialty like internal medicine or orthopedics or neurology. And so the PT student then has to have a self-motivation that I think the academy could look to and market, that these PT students and recent grads need to understand and need to be marketed, that the academy could be an avenue that is used both for looking at accredited courses that they should consider attending, or conferences like this one that they should attend, so that they can grow and look to areas of research that are going to maybe enhance their skill level to have better patient outcomes.
What is your vision for the academy as it continues to evolve?
That's a tough one, because when we first came to the conclusion that one of the criteria for the U.S. and its membership was that we were trying to get programs that would have residency education, and in other words, something beyond short courses. And so we felt that the academy would be able to accredit programs that were then residency bound. But when you look at the way our system has evolved, PT school costs a lot more now than it ever has. And so the amount of debt that the PT student is coming out of school is just a radical difference and influential factor on where that recent grad chooses to spend their time and their money. And then the fact that the electronic medical record keeping and the dictates of how much and how careful our notes that we have to generate for every patient treatment are today versus when I got out, and that could be handled very quickly. The progress notes that had to be done for patient care were just a lot less than what the PT is expected to do now for reimbursement, with third-party payers asking what I think are very unreasonable things. So those two energy takers, the fact that you have heavy debt and you've got to worry about that debt as you enter life, and the fact that there is a big drain on material to get payment of paperwork that's done, makes it so that the recent grad is compromised on their time in a way that, when you think back of what we were envisioning as founding 8 members, that we were trying to just get residency education off the ground, and then maybe residency education just for the pure satisfaction that you were getting patient outcomes that were better than what you would have had otherwise. That was a driving force, I know, within me, that I knew there is better ways to treat patients and have better outcomes, and I wanted a better education. And then I wanted to share that better education that I received from my mentors with others. And so the vision that we had at that time, I think, has been compromised in today's world by other factors that drain the new grad that's out there practicing from the same vision that we have of just getting better as therapists. Does that make sense?
Yes.
And so that's kind of a negative, right? It's a negative in that the vision that we had as a founding 8 is now compromised by other outside factors that deplete the recent grads' energy to want to focus as much as we had the opportunity to when we were young in our careers to focus. And that vision that we have now is going to somehow have to adapt if we're going to succeed. And we are going to continue to promote better patient care through the skills that we feel are definitely needing to be passed on. And the program that we wanted to have with this academy then helps others have an avenue to grow and get better And I don't know that how that's going to have to adapt, but I think that having a national body help us adapt, and a national body that can influence our national organization like the APTA to shape policy within our U.S. government is going to be a huge political factor that we have to have in order to sustain the quality of care that the founding 8 members were looking at when they originally came up with the idea for the academy.
Do you believe that AOMT will survive another 25 years, and why?
I believe that it will survive, but I'm not sure how it's going to survive and what roads that it's going to eventually take. But the reason I think it will survive is we all recognize that there are powers, like with Medicare, for example, that establish rules that we think are unreasonable, and they have reimbursement that's unreasonable. And we who are practicing physical therapy that we feel produces the best outcome are oftentimes do not consider it realistic for patients to have the restrictions that the national health insurance will place on the patient. And with that in mind, if we don't have a national body to turn to represent our skill level, to then bring forth to the APTA, and the APTA can bring towards the U.S. government through the Medicare system, then we're going to be in trouble. And I think because most people are going to be aware about their health, and healthcare providers are going to be aware about the dilemma, I think they will turn to a group like the American Academy to look for support in that endeavor politically, so that we can be a player. And part of that is to have evidence that suggests the high skill that we're purporting to have in the American Academy. Make physical therapists a key player as the aging population becomes a dominant factor and a burden on the Medicare system. So the whole thing about the role as physical therapists in outpatient orthopedics, especially keeping people out of convalescent hospitals and moving, is a key role, I think, in keeping this program alive, the Academy, and the Academy therefore having a snowball effect to the APTA, and the APTA as a national body to represent us in our profession to the Medicare system. Because many of the insurance companies are going to try to follow the Medicare role in how they adapt and what rules they have. And they already have for just criteria to be a Medicare provider. The other insurance companies usually follow Medicare.
That's all the questions I have. Is there any last comments you want to make?
I do feel that the growth of the Academy is been a beautiful thing, and I don't think that we ever, even in our first conference that we had at the Flamingo Hotel in Las Vegas, that beautiful pink building that's been imploded and no longer on the map, is where we had our first conference, and it was attended by a couple hundred. We never dreamed it would grow to over 1,000 that we had a couple years ago in San Antonio. And I think the people who took over the Academy, and the ones who then succeeded that next group of executive on the committee, and the following officers have done a tremendous job in making the Academy grow. And so my hat's off to those who have been a part of that whole transition over these last 25 years.
Great. Well, I just want to thank you, Michael, for everything